Good evening, everybody, and welcome to this UK FPO webinar as part of our education and support material. This one is entitled Patient Safety, an Introduction for Foundation Doctors. I'm delighted to be chairing this session. We have two speakers. We have Dr. Jeffy Liu, who is one of our UK FPO Fellows, and Dr. Helen Purvis, who is the Patient Safety Lead in NHS England. The housekeeping for tonight is that we are recording this session, and if you have any questions, we'd like you to pop them in the Q&A section, and we will answer these at the end of the session. So first thing I'm going to do is present my slides as a bit of an introduction. So my role is Fiona Cameron. I'm the consultant anaesthetist, and I'm the Foundation School Director in Scotland. And I'm also chair of the Academy's Foundation Programme Committee. With me tonight, I have got Dr. Jeffy Liu, who's an F2 and our UK FPO Fellow, and she is going to talk to us about the Foundation Doctor's experience of patient safety. Dr. Helen Purvis is a paediatrician and is the NHS England Patient Safety Lead, and she's going to give us some experiences of learning through PSERF, which is NHS England Patient Safety. I'm then going to talk through 4Nation resources, and then we have a Q&A session at the end. This presentation will be recorded and published on the UK FPO YouTube channel in due time. So I'm now going to hand over to first I'm going to talk about the curriculum requirements. So from 2025, all foundation doctors will be required to evidence patient safety in their portfolio. Currently, foundation doctors evidence patient safety as part of their curriculum, usually using quality improvement or perhaps through reflections as part of their learning and their experience. From 2025, this will be much more explicit, and all foundation doctors will be required to signpost that they have learned patient safety activity in their portfolio. They will also have to evidence that they have done some learning, and this might be face-to-face learning, either in the workplace or perhaps on Microsoft Teams. And there are also a huge range of learning resources in the different nations of the UK, and also on e-learning for health. We will expect the foundation doctors to signpost patient safety activity through their SLEs, through the reflections, and also through their summary narratives. I'm going to stop sharing now, and I'm going to bring on Jeffy, who is going to talk to us about the experiences of a foundation doctor with patient safety. Thank you, Jeffy. Jeffy, do you want to just introduce yourself as well?
Yeah, absolutely. I'll share my slides and I will introduce myself. Right. Hello, everyone. My name is Jeffy. I'm an FY2 doctor based in the northwest of England. I'm also one of the UK FPO Fellows. Today, I will be talking from the foundation doctor's perspective on patient safety and share some positive and some negative experiences I've had. So just start off with defining patient safety. So the definition on the NHS England website is the avoidance of unintended or unexpected harm to patients during the provision of healthcare. As foundation doctors, I'm sure we have been involved with or witnessed all types of patient safety incidents. On the right, we have a list of the most commonly occurring ones. I mean, I think all of us who have seen or been involved with some medication errors. I think the other common one is documentation. In my hospital, in particular, we use paper documentation. So there's always room for pieces of paper being lost or not documenting accurately who was at the ward round or inaccurate information. So these are just some of the common types. And I think the last one, communication error, probably is the most is one of the underpinning errors of all the errors. And I think that most of the errors that happen in the workplace that cause patient safety being compromised, if you kind of trace it back, a lot of it is to do with miscommunication. And that is something time and time again, we have always been encouraged to reflect on. The next thing I wanted to share is my personal experience as a foundation doctor of navigating patient safety incidents. I think very early on in FY1, I noticed that there is a lot of stigma around being involved in incidents. And this is something that stems back even as a medical student. I know that from my own experience and speaking to peers, everyone's afraid of being reported to the GMC. The GMC was seen as this big scary organization that would basically strike us off before we even were registered. And I think this fear continued on into foundation training. And this was particularly apparent when I myself was involved in a patient safety incident and I witnessed some miscommunication, poor staffing, and there was a bit of a near miss and I incident reported it, and which is fine, and it was investigated, the case was closed. But I remember came ARCP time, I logged this incident on my Form R, and one of the comments from the ARCP panel was, your portfolio is excellent. However, you have an incident on your Form R, and we have looked into it, and we found that you weren't actually named in this incident. And in which case, you really shouldn't be putting it on your portfolio because essentially it looks bad. And please, could you take it off and do a reflection instead? Which is fine. I mean, I think the reflection is valid, and I did do a reflection form on this incident early in the year. But I remember just thinking, why is there this culture of, try to shy away or run away from being named in incidents or being involved in these sort of events, when really this is showing one's proactiveness and learned attitude in trying to, take control of the situation and escalate concerns through the appropriate channels. And so this kind of leads on to me noticing things like, blame culture, whereby, when I was on my obstetric and gynecology placement, I definitely have witnessed some poor sort of communication and this tendency, especially when high acuity or pressuring situations happen, for there to be blaming between the obstetricians, the midwives, and then the anesthetists sometimes get dragged into the situation. Things get hostile and tensions rise, and patients unfortunately get caught in the middle. And I think this goes to show, and these are some of the negative things I would like to kind of emphasize on, that cause patients' interest not to be safeguarded because we're too busy trying to run away from these these factors, and not actually address them more constructively. I would say some of the positive experience I've had include having supportive seniors whom I could turn to and debrief with after witnessing patient safety incidents or escalating them. I always found it very helpful to debrief with my seniors, with my supervisors, and I think that reflection is something that's encouraged in our portfolio, and as foundation doctors, it can be done by writing a reflection. However, group-based reflection activities are also just as, if not more effective. And so this is something that I would highly encourage. And I think that now that I'm in FY2, and I've gained a little bit more experience, I find it really important to support the FY1 doctors who are coming in and perhaps feeling overwhelmed. And, when you're feeling overwhelmed, your clinical judgment will be impaired. And so it's important to check in on each other and make sure that we're feeling safe enough to continue on in the clinical environment. So, sort of a loaded slide, I wanted to now share some good practice in terms of patient safety training that's being done in the northwest of England. Lessons Learned is a mandatory teaching program that has been incorporated in the northwest. It is a peer-led teaching program, so it's foundation doctor-led. We have 6 sessions throughout the year, and it lasts for an hour. It's group based, and it will start with an anonymized case being presented on a patient safety incident, followed by group discussion on what are the contributory factors that led to this incident. And then following on, you have an action plan to talk through some of the things that we can try to change or quality improvement project ideas that could be implemented. And the whole idea of this program was to foster this open, safe culture where foundation doctors could debrief about these cases because it's anonymized, so there's no finger pointing amongst each other. It's in a more relaxed environment, but it's also to encourage them to be more proactive in these sort of proactive learners rather than just passive observers. This is an example of the template that we would use for this teaching. You can see that we have contributory factors categorized as patient, task or technology, staff members. This is just a snapshot of part of it. The others include organization or systemic factors. And the whole idea is to actually critically think about how a patient safety incident has happened, what are the factors that have led to it, and really break it down step by step so we can see where things actually went wrong. And then after we've done that, we then sort of once again brainstorm actions for learning, and we'll then map it or link it to the factors on the left. So some of the examples of actions would be, do we need to devise a proforma? Do we need to review the trust guidance on something? Do we need to have more teaching on a certain topic that people are not familiar with? Or is this something that needs to be escalated even further to our foundation program director or to the resident doctor forum, for example? And I think that this is just an example. I'm not saying that this is something that needs to be implemented throughout the UK, but I do think that this is a great way of delivering training and teaching on patient safety, as research has shown that the most effective form of CPD is group reflective activities, especially ideally in a multidisciplinary team with interprofessional learning, where you're also involving nurses, pharmacists, other people who you will be working with in the workplace. But even as a group of foundation doctors, it is extremely valuable to be able to sit down, reflect on things we witness in the workplace, debrief about them in a safe environment, but then also to be proactive and suggest actions to change what the current practice is and how we can take it to that gold standard that we're aiming for. Case discussions are quite helpful as used in the training program. Simulations are also very valuable. I didn't have time to include a simulation that I had done in medical school, but I know that there will be foundation doctors out there who are involved in simulation as simulation fellows, or they're interested in how digital technology can be used to deliver teaching. And this is a great way of delivering teaching on patient safety, as it allows the foundation doctors to immerse themselves in that environment without actually causing patient harm, if that makes sense. So they can get all the learning in simulation, but without the real patient factor. And I think that's extremely valuable. So these are just some of my key takeaways. And I will hand it over to Dr. Purves.
Thank you very much, Jeffy. I'm going to introduce Dr. Purvis now, who's the NHS England patient safety lead, and I'll let her introduce herself as she goes along. Thank you.
Hi, welcome everyone. So I'm Dr. Purvis. I'm a patient safety lead in my trust, and I'm a paediatrician by trade. So I'm just going to share my slides. You can So I'm going to talk a little bit about PSIRF, which is the acronym stands for the Patient Safety Incident Response Framework. It's what NHS is happening within England in the patient safety world. And essentially it's a framework of how we're going to look at patient safety incidents to get the maximum learning and to keep it that psychological safety that has sometimes been lacking from patient safety previously. So before PSIRF was in existence, and it's still in a kind of not a trial, it's being kind of implemented across the UK, well, across England, but it is still a work in progress, I would say, and every trust is probably doing it slightly differently. But before this existed, often if an incident was raised, if it was a serious incident, it would have a review. This was an extensive investigation. It required a lot of time and resources, and actually was not necessarily proportionate for all of the incidents. So sometimes it didn't capture all the incidents that were happening where there was still some real learning to be achieved. There wasn't really a structure for investigating any no harm incidents or incidents where there's learning but it's not appropriate. It didn't capture the psychological impact of incidents on patients or staff. Often that investigation would happen and then would, in good practice, would be fed back to patients and families, but they wouldn't have been involved in any of the investigation process up until that point. And sometimes there would be investigation after investigation after investigation where you'd have the same learning coming out at the site at the time. And the investigations were taking a lot of time. So you were doing more time on investigations than you were actually following through on action plans. And it gets back to this kind of principle of are we just counting where there's a patient safety concerns, or are we actually learning from our patient safety from our incidents? Because there's a lot of focus on trends and charts, and we celebrate when our incident reporting goes up. And then we investigate things because we know that there may have been harm, and we want to investigate because it feels like the right thing to do, but we're not necessarily investigating the real root cause of the problem. At RCA, a root cause analysis could take months to come to some answers, by which time there could have been another 3 incidents involving the same thing. And sometimes the recommendations and action plans were superficial. They scratched the surface, or they were repetitive, or they were so far delayed that by the time the incidents had been completed, you weren't getting the learning you needed. And ineffectual sometimes, an action plan would just sit there then, having exhausted all resources on doing the investigation itself. And as I said before, they rarely involved the patients or the staff in the actual investigation process. And really what PSIRF was developed was to try and improve and move from this way of learning to move to a way of learning where we are having a compassionate engagement with those who are involved in the incidents. And that means the families, the patients, the carers, but it also means the staff. Because actually, when incidents happen, often the feeling is that we should be looking at who was where, who did what, and we get the notes and we look through them, but actually none of the notes capture what happened on the ground. None of the information recorded is really clear as to the pressures on that day, as to the decision making that happened on that day, as to the fact that it took 10 minutes to find the bit of equipment you want because somebody had put it somewhere else or it wasn't ever kept in the same place. And really getting to the root of what is causing some of the patient safety issues that we have is really getting down to that minute detail. The people that know what those things are the people that were there at the time. And the patients, sometimes we've done investigations, and recently I shared an investigation with a family that was on the old system, and I shared it with the family. And when we sat and spoke to the family, what was important to them was how they felt as their loved one was in that particular case dying, how they felt the care was on the ward, how they felt how it was to be able to hear the Coronation Street in the background when they were trying to give end-of-life care to their relative who was on an open ward. And those things weren't captured in the investigation because we didn't ask that question. We didn't ask them how they felt. And actually, some of what we need to learn from incidents is about how our families and carers are impacted by it, and our patients are impacted by those things that don't go as we would expect. It also that looks at the systems-based approach. So it looks at the whole system rather than looking at individuals, individual caregiving, individual wards, locations, because actually often the majority of patient safety incidents could happen anywhere at any time. And there will be nuances about the wards that they're on or the nuances about the particular situations, but actually we should be looking at addressing those issues that come across the whole system because that's how you're going to make the patient safety better. The response needs to be considered and proportionate. And again, this gets back to the fact that there has been a bit of a blame culture, as Jeffo mentioned earlier, that feeling that if I do something wrong, I'm going to end up with this, that, and the other consequences. And actually, sometimes there has been, most certainly I've seen it and observed it in my training and still observe it today, sometimes that feeling of somebody is looking for somebody to blame. And actually, that response has to be proportionate. Yes, sometimes incidents occur where there has to be a bigger response, but often the majority of responses, it needs to be reflective of the actual incident and what the learning is from that incident. And then the final one is something that will affect how the system looks at its incidents from a more higher level, and that oversight, and that people aren't just in their own little areas doing these little investigations and having different ways of looking at things. So in my trust, for example, we have a reflect medication reflection form that the nursing staff fill in every time there's a medication incident, but the medical staff very rarely have to fill them in. Now they fill them in my department, but they don't fill them in every department across the trust. So the nurses are learning and reflecting on the incidents that happen around medications, but if a medic is involved, they weren't being asked to do the same thing. And that oversight is about standardizing how we respond so that everybody is learning from all these things at the same time, and that we are strengthening that process so that the response is a system-wide response as well as a system-wide investigation. And so just picking out the keywords from what I've just said, the changes to the new system is that it's proportionate, that it's compassionate, so it's involving families, patients, staff involved. It's system-based and it's being overseen by those higher up within the trust, so they are having some oversight to ensure that it's a fair and balanced process. And we're not wasting time and energy reinvestigating the same thing where we know what the problem is. And this is a bit of a busy slide, so I'm not going to go through it in a lot of detail, but I've put it in the presentation so that you can look at it in your own time. But basically, it's kind of goes through similar to what Jeffo was saying from the lessons learned. And I'm also in the Northwest, so I facilitate some of those sessions. This is what system-wide means. It means considering what was the task? Was there anything particularly affecting that individual? Had they not had a break for a long time? Was there specific issues with the rota at that time? Was there some difficulties or complexities in the task that they were asked to do? Were they asked to do a task that really shouldn't have been their task to do? Was there an issue with the physical environment? Was it a corridor? Was there a bed in a corridor? All those things that come to play to cause what happens, that outcome that you see that raises that incident. And you cannot improve patient safety by just putting another email out to all the trainees to say, do this. That isn't how we improve patient safety because the issue is usually much more system wide. So there are a few tools to help us. And again, I'm not going to go over these in a lot of detail, but these are, some of them are similar. So there's still a PSII, which is similar to what would have been a serious case review. However, there is sort of other options that are less detailed, but get to the point a bit quicker. So an after incident review is a quick review where there is a multidisciplinary focus to look on an area of improvement and try and move that forward so that we can make those system-based changes.
A swarm is a very immediate within the first 24 hours where everybody goes to the area and you do a quick review because you're looking for immediate patient safety issues. So that would be probably those more serious incidents, all those more serious patient safety concerns that have come out from your incident, but it would be a quick thing. It would lead on probably to other things, but that's your initial safety kind of part of your safety process. And then MDTs, which are similar to what you would do as an MDT clinically, but where you're reviewing all the incidents that have happened and what might need to happen to be different and what groups are being affected and how one group can help support prevent that happening again with the support maybe of another group. So something like falls might fall into that category in the sense that you probably need your medics, your physios, your geriatricians potentially, your ward staff to try and figure out where are the issues that may be led to that event. And then thematic reviews, which I have to say is probably the one that I like most out of all of these investigations, because it's where you take a whole lot of different incidents that are all along the same theme and look at really what is the common trends, what is happening across them. And usually, as I said before, you find that the incidents are happening repeatedly and they're slightly different every single instant. But when you look, there's a common theme. And actually, by addressing a common theme, you can have a much bigger impact on patient safety. And really, it still is a bit of a learning curve in the sense that there is lots we can still need to learn about patient safety, but the actual incidents, so the mistakes as such, only account for a very small proportion. So there's a huge amount of learning that we need to find ways to tap into in that what went well. And sometimes it's when things are a bit challenging, but they go all right. So you don't get an incident, but actually those little challenges you have on a day-to-day basis when you can't find your bit of equipment or whatever, those are the things that ultimately at some point may contribute to an error or an incident happening. And that we should be trying to find a way to address those. All of those near misses, all of those ones in between. And then the real positives, when you go to so I went to a delivery where the communication was so excellent that the team was there, the right team was assembled with the right piece of equipment, and that was all based on the fact that the communication was so good that everybody who needed to know knew and was there and ready to go. And that's a way of then going, well, when that goes well, why does it go well? And we should probably start to think about that a bit more too. In terms of the foundation program, and I know Fiona's covered this a little bit at the beginning, and Jeffrey has spoken about her experience of it. You can reflect on incidents that you have not been named in if you have seen those incidents and been involved in them in some way or have had them shared to you. And you can reflect on teaching in the same way. So if you get teaching such as where somebody is presenting it, a lessons learned session or whatever a case, then there is learning to do. And patient safety comes into various bits of the curriculum, as I've outlined here, in that contribution to safe ongoing care, on your quality improvement, in your ethics and law. A lot of the quality improvement that you do will be based on something that has happened before that has prompted the need for a quality improvement project. And it's a good place to start from because you know that something isn't going as well as it is, so we need to change it, and then your quality improvement comes through. Your Form R, you have to record, and you've got an obligation to record in your Form R if you've had a significant event that you have been named in. And I suspect this is where Jeffrey was questioned a little bit from this. It is really important that you reflect on them, but that isn't a negative. And we need to get away from the culture that this is a negative. Being involved in incidents and learning from incidents is what we want everybody to do. And that's why the patient safety incident response framework has been developed to try and really bring people along on a more psychologically safe journey so that we can all improve our patient safety. And as I said before, my key message is that you can only have patient safety if if there's a system where everyone is prepared to learn. And that means everyone from the board right down to every member of staff that works on the shop floor, regardless of role. Because once everybody is prepared to learn, then we can make improvements we need to keep our systems safe despite the challenges. I'm going to hand you back now to Fiona.
Thank you very much, Helen. That was really comprehensive and very interesting. Just before I continue sharing my slides here, one of the things that we have to think about when we're thinking about patient safety within the curriculum is that there's different terminology. And the foundation programme, as you know, is, or maybe you don't know, is a 4-nation curriculum. It's a 4-nation programme. That then makes things a little bit difficult sometimes, because different health structures use different terminology. We've just heard from Jeffy and from Helen about Form R. Form R in Scotland doesn't exist. We have something called SOAR, which is Scottish Online Appraisal and Revalidation System. And if you're working in Scotland, and I don't think this happens in Wales or Northern Ireland, I think they use Form R, but in Scotland we use a SOAR form, and it's used exactly the same way as Form R, and it's electronic. And in Scotland it's only for our F2s and not our F1s. And that brings me on nicely to think about terminology. If you go into various resources that are available, then you might see some terminology that you don't recognise. Patient safety across all 4 nations in the UK is the same. It has to be. Patients are patients wherever they are based in the UK, and our structures and our processes are all very similar. And also the incidents are very similar. But given the nature of our devolved nations and NHS England, we sometimes give people titles that change and are different. So when you're looking at resources, don't think, oh, I don't know what that is. We don't have that person. You will have that person. They may just have a different title. And the person to ask, the people to get information from, are the safety leads in your organisation, and your organisation will know exactly who the safety leads are, as will your foundation school contacts. So that's really important, and that you remember that. So what I'm going to do is I'm going to just share some resources for you. So as I said, we have 4-nation resources, and NHS England has PSERF that we've just heard about. And when you log on to this link, click on this link, you will find a huge range of resources that are available to you for your learning. In Scotland, Scotland is NHS Education for Scotland, and their NHS, their patient safety learning is through TURAS. And if you click on these links, you will find the patient safety zone. It is very much multidisciplinary for healthcare providers, both medical staff, nursing staff, allied health professionals, and is very comprehensive. There is an iHub, which has got a lot of resource that you can use with some suggested tools for whatever specialty that you are working in. Most of these are not foundation specific, but are specialty specific, and are available for all grades of staff, and including our non-medical and our medical colleagues. If you are working in Wales, then that's HUI. There are some government documents about quality and safety, and if you click on that, then you will access Welsh specific patient safety. If you're working in Northern Ireland, again, if you click on the education resources within your organisation and with NIMDDA, you will find links for patient safety activity. So I encourage you to look at these resources. If you are considering developing some patient safety work, getting some ideas, and also just for your learning. So as we know with the curriculum, you have to reflect, You have to be core to everyone's job is core to development of patient safety. But as you know, as a foundation doctor, you're expected to demonstrate some learning. You have to sit down either in a lecture base, a tutorial base, or do some online learning. And there are a lot of resources for you to do that. So if you look at the NHS patient safety syllabus, this is what you will see. This is what it will look like. This is the front page. This is what you will look at when you open the Scottish Patient Safety Programme, and you can see that it is themed for the different components, the essentials of safe care, the programmes of work, and also a learning system. Patient safety has human factors, and the big important thing to tell you about is the Academy of Medical Royal Colleges and NHS England's Patient Safety Programme, and that is accessed through the resource, through PSERF and the resource that I have already linked to with you. It's important that you work your way through the Academy Medical Royal Colleges and the e-learning for health modules, which are extensive and will meet, from your curriculum point of view, they will meet everything that you need from the core learning aspect. And if you if you read the module, it shouldn't take you too long. We would actively encourage you to look at NHS England's e-learning for health modules, which are excellent. If you're in Scotland and you want to use, or the other three nations, you can use your local resources, but I would suggest to you that these resources are incredibly helpful to you. One of the things I want you also to think about is not just about reflecting on an incident. And one of the things I hear from foundation doctors is, I don't know what to write for patient safety because I haven't been involved in an error. I haven't been involved where somebody has come to harm. But everybody is involved in the promotion and the development of patient safety. And it's not just about things that have gone wrong, but it's important to reflect on when things have gone well. So on that note, I'm going to thank our speakers very much for their excellent contributions. And I'm now going to open the questions for the audience to ask. So the first question I'm going to ask Jeffy is, one of the things you commented on, Jeffy, was about people not wanting to comment about putting things in their portfolio if they've been involved in an incident. How do you think we can encourage our foundation doctors of the future to be open and honest about putting things in their portfolio? Because there is a fear. I also hear that people maybe not want to tell their supervisor in case it reflects badly on them, that something has happened, either their error or something that, what they perceive as their error, rather than just being involved in a circumstance, in a situation. How do you think we can promote that within the UKFPO, Jeffy?
So I think that it all boils down to the culture, isn't it? Culture, whether it's at the level of the trainer or the supervisor and at the level of trainees. And I think that personally, I had a really good educational supervisor in Foundation Year 1. Who provided that pastoral support for me, and she actually reached out to me because she had looked at my portfolio ahead of our meeting and saw that I had written a reflection. It was very emotive and sort of talking about how I had an on-call experience, which was very overwhelming, and I felt like patient safety was being compromised. And she immediately reached out to me to first of all find out if I was okay emotionally, and then said, let's talk about this at our meeting. And we can think about what we can learn from this and just try to put things in place and just debrief about the entire situation. So I think that it definitely requires effort from both the supervisor as well as foundation doctor. I do think that when trainees start out, they are probably just terrified of everything because they don't know the system well, whereas the supervisors have been in the system for a lot longer. So I think it would be great to include this aspect of this culture of come to me if you feel like you have witnessed anything in your workplace that compromises patient safety and you yourself are feeling overwhelmed about it. And I think that if supervisors can make that quite clear from the start, that they are just open and approachable, I think trainees would feel a lot more comfortable going to them and disclosing these matters, and we can try and resolve this the best way possible. It doesn't always need to be reportable. It really is quite dependent on what the situation is. But I think that's my line of thinking. Culture shifting.
Thank you. And kind of what that's really helpful, Jeffy. And on that line, Helen, I mean, maybe I work in a very harsh environment, but some of the things I hear from our foundation doctors is that the nurses, we have our reporting systems is DATEX. We use the DATEX system in Scotland as our reporting tool. And some of our colleagues have used the word DATEX as a verb. And we hear from the foundation doctor said the nurse said they were going to DATEX me for that, and that has provided a lot of fear. How do you think we get over those barriers? Working in a multidisciplinary team, because we're all there for the same purpose. Every single one of us, including the cleaning staff, everybody is there. So Helen, how have you managed to build that into your in the organization you work in?
Yeah, and I mean it is a common fear that and I've seen incidents put in where there has been that kind of very personal angle and they're used in that kind of way. And ultimately it gets back, it is about changing the culture. It gets back to the same thing that Jeff said about the culture of reporting. And also it's about us really getting underneath what is happening in those situations where that kind of reporting is happening, because it is more to do with a frustration within the system often, and that the DATEX is being seen as trying to work through a frustration in a system where there is a bit of reporting of things because we don't know where else to go with that information. And the way that we have been working with our teams is about really opening up that culture of, right, if it's not feeling okay, let's say it's not feeling okay now, let's not wait for an incident to happen to say this is not feeling okay. And really keeping those channels open of frustration with each other and across teams, and how teams are communicating with each other on the ground, because often it's a misunderstanding of what each team is dealing with and a feeling that we're not being listened and heard that tends to lead to those kinds of incidents. And role modeling, what I often hear about the frustration from our foundation doctors is that they're putting in incidents with real concerns and not feeling like they're hearing the right response. Either they're getting no response or they're getting a response that very much plays down the incident that they feel was really important. And we know that incidents take time to put in. It takes some energy to think about your incident and put it in. And therefore, if a trainee or anybody has put an incident in, then we have a duty to make sure that that is heard. Whether we are saying, actually, we know about this and we have a plan in action and this is what we're going to do, or whether it needs more unpicking than that, then we need to be giving those incidents enough time to show that we're listening, but also not wasting energy on incidents that are repeating the same thing because we know we've already got that issue going. And I think it's about keeping that conversation open. The other thing that I have done with the trainees is I meet with the trainees quite frequently in their foundation teaching, and sometimes those sessions are often where there's been a sudden gap, and I sit down and just listen, and listening to your junior doctors and listening to all your team in a very non-threatening, non-planned way is actually seems to me has been to me the most useful. I know more about what's going on the ground from sitting and listening to people than some of the incidents that we're getting put through. So it is a big culture change, and it is about sometimes you do have to address behaviours that are not what we are looking for either. But ultimately, it's about really getting to understand the feeling that somebody had when they put that frustrating incident in that feels quite accusational. And then once you do that, you find that that carries on the next time. People don't use incidents in the same way, and people start to learn about what the benefits of incident reporting is, as opposed to using them like a threat.
Thank you, Helen. That's really helpful and very uplifting and encouraging. Obviously, Jeffy, you're moving on from foundation, but our new doctors are applying and coming in, and Helen has very nicely detailed within the curriculum the FPCs, the foundation program capabilities, where patient safety can be promoted. And what we would love and what we're hoping for is for a portfolio that promotes patient safety and has patient safety at the heart of everything a doctor does, not just a foundation doctor, but everything that we do in our clinical practice and also in our non-clinical practice. How do you think we in the foundation programme could help promote these curriculum links? I mean, obviously we can list them, we can say you can link it to this and this, but how can we get across to our foundation doctors that it's a really positive thing to create those links and put them in there? And I'm thinking not just negative things that happen, but also positive things that they've seen. And maybe that's a hard question for you, Jeffy, but what would you like to have seen if it was you doing this?
Yes, I think there is something. It's the opposite of data or incident. Someone mentioned it to me. It was in the mandatory teaching, and someone said, did you guys know that we actually have one of the icons on a desktop is to do the opposite of an incident, where you actually talk about a positive, or just commend something that has happened positively in the workplace. And I think this is about, once again, changing cultures, reinforcing good behavior, celebrating when things are really done well. And I think some of the things that we do, I remember in Ops and Gynae, we used to have newsletters where we would, share good practice that's happened, good statistics, when things, and also sort of showcase maybe one of the staff members in the MDT who has demonstrated good leadership, good patient safety awareness, boosting staff morale. So I think showcasing and highlighting good practice and sort of giving people who are working really hard to maintain patient safety that platform to share what they have learned, what they would recommend. I think these are all uplifting ways that could be linked to the curriculum. And in particular, this opposite of an incident, which I, for the life of me, cannot remember what the name is. I think that's a really good way, and you can actually link it to your portfolio and say that you have been named, this patient safety champion of the month, and that looks good on the portfolio, and that's always something that foundation doctors would be interested in. It can be mapped to all the curriculum outcomes. I think that the lessons learned, the one that I mentioned, the teaching program, peer-led group teaching program, is positive. And it's one way of linking it to the curriculum, but it's a very pragmatic and practical way, sort of getting all the good discussions going without feeling like it's just being delivered in a more didactic way.
Thank you, Jeffy. I wonder if the term you're looking for is a greatex. Is that the term you're looking for? Certainly, where I work, we have a sort of learning for excellence, and somebody doesn't get a datex, they get a greatex. And my understanding is that, and I don't know this as absolute fact, but I believe if you get a great exit, it helps for your specialty or GP application. I believe that gives you a little bit extra. But again, I'm not absolutely 100% sure on that, but it's certainly a very pleasant thing to receive. One of the questions that has come in is what is most interesting or surprising that I've learned while preparing to discuss patient safety. So I mean, I haven't answered any questions yet, so I could take this one. So I'm actually really overwhelmed by the amount of excellent resource that is available to our doctors and to all our healthcare professionals. And whilst there is difference in the wording and the terminology about the passion that is out there in promoting safe patient care. I also like to walk the walk as well as talk the talk. And as part of this, I use e-learning for health, and I logged in and I sat and I worked through the Academy of Medical Royal Colleges and NHS England's e-learning for health modules on patient safety, and I learned. I thought it would be straightforward and I would know everything. As a relatively experienced clinician, I've been here for quite a long time, but I did learn. I learned about structure. I learned about planning for patient safety. I learned about it's not just about making sure that the drug chart is correct, but it's all about staffing, it's about resource, and it's about not having a blame culture. So I have sat and done the modules and also linked them to my appraisal portfolio, because that's never a bad thing to do. So I think for me that has been the most interesting thing in preparing. Sit there and do the modules myself, and it didn't take too long. So I would commend them to everybody. So is there anything the panel would like to add, Helen or JP? Have we covered everything?
I think what I would like to add is just don't be scared of patient safety. I think patient safety is ultimately why we're all doing the job we're doing. We're doing it to keep our patients safe. And so it shouldn't be considered a negative thing. What it should be considered is part of your day-to-day practice. And I think sometimes when you're trying to do portfolios and map everything to curriculum, I think people worry about where does this fit in, but it fits in across everywhere. Every single case of patient, every single reflection will have an element of patient safety in it. And sometimes it's just recognizing that. And if you do the modules are very good and haven't been in existence for a long time. When I started this job as a patient safety lead, I tried to find education for myself, and there was very little out there, but they are fantastic modules and they do give you a different viewpoint. And when you do them, you will realize that the reflections that you are making or the incidents you're seeing, you'll realize where they fit into your curriculum and which bit of what you're doing every day is fitting into those things, because it's understanding that. And as I say, don't be afraid of it. If you talk about patient safety, if everyone talks about it in a positive way, then we won't have this negative culture around what is safe and what is not. And it won't be used as a weapon, because sometimes it is the same. This is the patient safety incident, so we get it on the top of the agenda, but everything we do is a patient safety risk, and could be a patient safety incident. And if we keep that at the forefront, then on your day-to-day practice, you'll be doing good things for patient safety every day. And it's just realizing that, reflecting on that, and then trying to make the improvements where you can with the support that you get.
Thank you very much, Helen. These are really uplifting words and really inspirational. So I think our time is up for this webinar. And again, I would like to hugely thank the team at the UKFPO for providing this platform and the support for us to deliver it. I would like to thank Dr. Helen Purvis, for her inspirational talk with the resources and advice. And again, to Dr. Jeffrey Lau, who has our foundation fellow who has again supported the webinars and has provided useful insight into the experience as a foundation doctor. Can I just remind everybody about the wonderful piece of work that Jeffy has done called Humans of the Foundation Programme Project. The slide is on the screen just now, and if you haven't already looked at it, I can strongly commend that to you. And of course, you can always link this to your curriculum, probably we're thinking about the wider aspect of medicine amongst other things. And I know that ARCP time is looming, and you might be looking for some other links. And as well as it being incredibly interesting and useful, then it will also help you with your ARCP. So I'm just going to close this webinar now and hope that you have found it useful. So thank you very much for joining. And if you have any further topics that you would like the UKFPO to deliver, then please email them to the email on the screen just now. Thank you very much. Good evening.